Good morning, everybody, and welcome to this Sunday morning. We are doing a EndoUrology OSCE under the ISU USI. Today, we have Dr. Arvind Ganpule and his team who have designed these questions. And it's a new way of teaching. According to me, it's not only an exam, it's a new way of teaching because the faculty will have put in a lot of efforts to tell you the rationale for the answers which they are going to give. So I hope all of you would benefit from this. We had a good feedback of the andrology OSCE we did the first time. That's the reason we thought we will do for all the subspecialties. And Arvind and his team has put in a lot of efforts for this. With this introduction, I would now invite Dr. Rajiv Sood to give his introductory remarks. Over to you, Dr. Rajiv.
Thank you, Dr. Keshav. As you have already mentioned that this is a new way of teaching, and I think two factors have played important role. One was that this was in COVID pandemic times, and the second, how the National Board of Examination tackled the situation was by this way of examination, OSCE, and the third thing is that the success of andrology men's health OSCE, that was the inaugural OSCE, that has given us more reasons that this way has been adopted by ISU and USI already. So this is going to be the norm of one of the chapters of teaching, one of the ways of teaching, and therefore all the stalwarts are there, and EndoUrology is doing very well. Last year also it has done very well in all the programs, and Dr. Ganpule has now drafted this program for all the residents. I think all are going to be benefited, and if we are talking about second wave, third wave of corona, or maybe the scare of corona, maybe that national board goes back to this kind of exam again in the coming examination. Last time it was reverted to the normal way, but it may again be reverted to OSCE type of examination, and the reasoning, how the rationale of answers, how to tackle each situation, and quickly. It is time bound. Everything is time bound, and that is very important to understand and practice. And with this, one more goal is achieved. We have subspecialties, and each and every subspecialty of urology is going to be touched by this kind of examination. So we are equally prepared when we are going for exam or going for our studies, and therefore this is the program. And I wish all the best to Dr. Ganpule and all the members of EndoUrology team. Back to Dr. Keshav Murthy.
Thank you, Professor Sood. I would now invite Dr. Arun Chawla to give us the introduction and the format of the examination. Over to you, Dr. Arun.
Thank you, Dr. Keshav. Regarding the OSCE, Dr. Keshav and Dr. Rajiv Sood has amply cleared that why it has come in. Regarding the format of OSCE, I think one word of Dr. Arvind Ganpule in a short video has already been circulated to you and has been sent by mail also. But again, when he starts this this OSCE exams, it will be clear to you the number of OSCEs, the questions which are framed in that question, the time limit given to answer each question, and the choices which we are seeking from you in the answers, and the allocation of marks. I think Arvind will, in his first slide, will make it very clear to you. All the marks will be then summed up to give a total score. And as Dr. Keshav has pointed, all these OSCE scores are being collated to give an overall sum score for the awards during the annual conference. With this, I'll just wish Dr. Arvind Ganpule, the chairman of the EndoUrology cell, and the other members for the success of this OSCE program. And with this, I hand over to Dr. Keshav, back to you.
Thank you, Professor Arun. Now I would invite Dr. Arun Ganpule for the program to be conducted. Over to you, Dr. Arun Ganpule.
Thank you very much, sir. At the outset, it is indeed an honor and privilege that the USI and ISU has considered ourselves to be worthy enough to conduct this OSCE style examination. I hope we'll reach up to the expectations of all the seniors and professors. So before we get started, I must acknowledge that I have been helped by my by cell members, and of course I would be failing in my duty if I don't mention Professor Arun Chawla and Professor Keshav Murthy for the help and the guidance they have given me while chalking out the OSCE questions. And of course, one particular person I want to acknowledge is has helped me in this particular endeavor. Just to go ahead and set the ball rolling, a few important points I want to mention and the outline that we are going to follow in the next 2 hours. We will be having 15 case scenarios with multiple questions in that particular case scenario, and each question will be allotted 20 seconds. What the candidates have to do is that they have to note down the response on the paper. Very important that please mention your name and USI number if you have got a USI number on the paper. There are a total of 15 OSCE case scenarios with a total marks of 120. The number of marks that have been allotted for each case scenario vary a little bit, and I will be showing the number of marks that has been allotted to a given case at the end of the case. The questions will be shown or discussed over a period of 1 hour. The response have to be scanned and the paper on which you have written the responses have to be sent to this email ID. I'll read it for you: osce2021exams@gmail.com. This has also has been noted on the chat box. It is very important that you submit all the scanned or photographed copies within 10 minutes of completion of the question session. Scans received after this time will not be accepted for a very simple reason that we'll start giving answers to the questions for the next 1 hour. So it is very important that you send your scanned copies to this Gmail ID within 10 minutes. The individual feedback would be communicated to the candidates, and as Professor Keshav Murthy and Professor Arun Chawla has already alluded to, that the marks will be collated and the final 1, 2, and 3 will be announced later. So we go to the, we start the OSCE, this one. We straightway go to the first question. I will be presenting 3 questions and all my colleagues will be subsequently presenting 3 each questions. I will be conducting the whole thing through the slides which will be shown from my end. So the first question is as follows. A 32-year hypertensive male presented with complaints of pain in the left flank, intermittent, dull aching in nature for 1 month. This is the X-ray KUB, and this is the CT scan picture. You can see that there is a 17.7 mm stone in the lower calyx. So question number 1, according to the EAU guidelines, which are the 3 most preferred treatment options for such a stone? So your time starts now, 20 seconds. We go to the next question. The patient underwent an ESWL 2 sittings outside before coming to us. After 4 days, he returned to the emergency department with abdominal pain. He had tachycardia. He had got a high blood pressure 160/115. He was pale. Per abdomen examination revealed tenderness over the left flank. And these are the imaging findings, ultrasound and the CT image. Just have a look here. His hemoglobin dropped from 10.2 mg/% to 6.8 mg/%. Total leukocyte counts went up from 8,200 to 2,500, and his creatinine went up to 3.3 mg/%. We go to the next question. What is the most likely diagnosis? Your time has started. Next question. Mention 2 causes for patients' deranged renal function. The time has started already. Next question. Mention 4 principles for further management of this case. Mention any 4 main principles to further manage this case. Time up. Now we go to a few general questions. Enumerate any 5 complications of ESWL apart from Steinstrass. What is the incidence of Steinstrass after ESWL in general? 3 marks. The time has started. Next question. Enumerate any 4 principal mechanisms by which stones are disintegrated with ESWL. The time has started. Enumerate any 4 principal mechanisms by which stones are disintegrated with ESWL. Time up. Enumerate any 4 risk reduction strategies to reduce complications in ESWL. Four risk reduction strategies to reduce complications in ESWL. So with this, we finish our first case scenario. So this case scenario had got total of 16 marks for the total of 120 marks. We jump to the next case. A 52-year-old female with no comorbidities presented with flank pain since 1 year on and off, no other complaints. Examination was unremarkable. By and large, her investigations, hemoglobin, total count, creatinine, RBS was normal. Urine showed 10 to 15 WBCs, culture was negative. Her serum calcium was 11.5. This is the X-ray KUB. And these are the CT I-view images. So we go to the first question. What is medullary sponge kidney? What are the characteristic findings on IVU or CT I-view of this entity called as? The time has started. Each part of the question will carry 1 mark each. Next question. Mention any 2 differential diagnoses you would think of in this case. Mention any 2 differential diagnoses you would think of in this case. Enumerate any 6 indications of metabolic evaluation. Enumerate any 6 indications of metabolic evaluation in a case of stone disease. Name any 4 methods of commonly used stone analysis techniques. 2 marks. Name any 4 methods of commonly used stone analysis techniques. 2 marks. Name biochemical and imaging investigations for evaluating hypercalcemia. You require to mention 2 biochemical and 2 imaging investigations. Mention 4 main principles of treating acute hypercalcemia. Acute hypercalcemia. Mention 4 main principles of treating acute hypercalcemia. So with this, we come to the end of the second case scenario, second OSCE. The total marks for this OSCE were 13. We go to the next case, OSCE number 3. 45 years old female complaining of flank pain, no other complaints. Per abdomen normal, examination was normal. Investigation showed an hemoglobin of 12.1. Urine routine analysis was normal. This is the X-ray KUB of the same patient. This is the CT IVU finding, a lower calyx stone. A further investigation was done in the form of CT KUB, which showed an left lower calyceal 14 mm stone with a Hounsfield unit of 1239. So the first question is, as per the EAU guidelines, what is the ideal imaging modality of choice? We want as per the EAU guidelines. Next question. Mention 2 significant points as regards Hounsfield unit of a stone which can help in management. Any 2 significant points as regards Hounsfield unit of a stone which can help in management. Mention 3 treatment options as per the EAU guidelines in this case. Mention 3 treatment options as per the EAU guidelines in this case. The mark distribution will be 0.33, 0.33, and 0.34 marks for all the 3 options, each of the 3 options. Name 4 points relevant to the lower calyceal anatomy which have a bearing on treatment outcomes. Name any 4 points relevant to lower calyceal anatomy which have bearing on treatment outcomes. Each point will carry 0.5 marks. So with this, we end the third case scenario. This case scenario had got a total of 6 marks. So I asked Dr. Harpreet Singh to present the next case. I will be controlling the PPT. Harpreet will be presenting.
Thanks, Avin. I thank USI and ICU for giving us this opportunity. A 45-year-old male complained of right flank pain since 3 years, no other complaints. On examination, per abdomen normal findings. His hemoglobin is 12.3, creatinine 0.8, and this is the CT IVU, right? So first question is, mention 3 important imaging findings on imaging seen in this case. So you have to mention 3 important findings. Have a good look at imaging.
Time up.
The second question is, name 2 suitable treatment in this case. You have to suggest 2 suitable treatment options in this case.
Time up.
Third question is, name 3 radiolucent stone other than uric acid stone. So suggest 3 radiolucent stones other than uric acid stones. So fourth question is, name 2 stones which are not seen on CT and X-ray. You have to name 2 stones which are not seen on CT and X-ray. This question carries a total marks of 9.
Time up.
Right. So we go to next question number 5 now. So here is the X-ray QB. You can see very well. So question begins. First question is, name 4 stone scoring system useful in managing renal stones. You have to tell us the stone scoring system, 4 of them, right?
Time up.
So next question in this, what is the next investigation? You have to give us 4 important points of information a clinician would like to know from the next investigation. So you have to suggest us which investigation is next and the 4 important point of information a clinician would like to know from the next investigation.
Time up.
Right. Third question is in this, mention 4 most likely composition for this stone. See the X-ray and mention 4 most likely composition for this stone.
Time up.
And the last one is, name 4 bacteria producing urease other than Proteus. So you have to name the 4 bacteria, urease producing bacteria other than Proteus.
Time up.
Total marks was 8 in this case. Yeah. Now we're going to question number 6. So 65-year-old male, hypertensive, complains of slow stream of urine and straining since 2 years. History of some lower tract intervention 10 years ago, no details available. DRE examination show grade 3 prostate, hemoglobin was normal, creatinine 1.1, urine routine nothing significant, PSA 2.1. Ultrasound show bilateral normal kidneys, prostate 90 gram and PVR 130 ml. You can see the Uroflow, wider volume 149 and the maximum flow 8.9. The ascending ureterogram is there. There are 2 views of that. So first question is 4 important examination finding to look for in a local examination. So physical examination or clinical examination, what 4 important things you will look into? Mention any 3 findings on ascending ureterogram. 3 findings which you see on the ascending ureterogram. What are the 2 treatment options available in this patient? So you have to suggest 2 treatment options available in this patient. Fourth question, what are the reported recurrence rate after primary DVIU and secondary DVIU. Recurrence rates you have to suggest us after primary and secondary DVIU. Fifth question is, name 4 biological modifiers used to reduce recurrence of stricture. But you have to suggest us 4 biological modifiers used to reduce recurrence of stricture. So this question carries 10 marks. Thank you.
Over to you, Rahul. Rahul? Rahul,
Yes,
are you unmuted?
sorry?
Yes. Are you unmuted?
The first case. Am I audible? 75
Yes,
years
sir.
old diabetic presented with history of LUTS for 1 year, aggravated in the past 3 months, increased frequency of micturition, poor stream. There is no history of urethral intervention in the past. On examination, the external genitalia is normal and the prostate is grade 2 benign with a palpable bladder. So my first question is, what are the components of IPSS score? Second question is, how does the AUA score differ from the IPSS score? What are the indications of urodynamics while investigating male lower urinary tract symptoms? And how is Abraham Griffith's bladder outlet obstruction index number calculated? Name 4 newer minimal invasive modalities in the treatment of lower urinary tract symptoms apart from lasers and TURP. This is the urodynamic. You can go through this urodynamic, and the question pertaining to this is, enumerate 4 important findings seen on this urodynamic. So the total marks for this is 12 marks, this question. This is the second case now, second case scenario. These are the instruments. These are the 3 instruments. The first question is, identify each of them Each carries 1 mark. The second question is describe one use of each. The third question is mention any 2 uses of a broken loop. It carries 2 marks. Next question, the total marks are 8. The next scenario is, look at this picture. The questions are, first question is, name these instruments. Second question, give specific uses of each one.
So the total marks for this OSCE were 6.
6.
So thank you, Rahul. So the next case will be presented by Dr. Deepak Raguri. Over to you, Deepak.
Thank you, Dr. Arvind. Going forward, let us take the 10th case scenario. A 55-year-old diabetic male presents with lower urinary tract symptoms for 15 days with history of fever, chills, and rigors. On examination, on a digital rectal examination, a tender prostate and bogginess present. The hemoglobin is normal. Total leukocyte counts is around 14,800. Creatinine is normal. Serum PSA is 15.5 nanograms. Sugars, random blood sugar is around 272, and urine examination shows pyuria. Now, your first question is, what is the most probable diagnosis and predisposing cause? 2 marks. What is the most probable diagnosis and the predisposing cause? Coming to the next question, what is the investigation to be done at the outset to clinch the diagnosis? What is the investigation of choice? Yeah, and that is the finding, the ultrasound finding, where the prostate is around 74 grams with an interprostatic confluent and discrete hypoechoic areas, which are approximately 5 into 3 into 2 centimeters. What are the principles of management of this condition? What are the principles of management of this condition?
So the total number
total
of
marks here is 5. Let's move on to the next scenario. Excuse me. It's a 25-year-old male who presents with recurrent gross hematuria. History of right PCNL done 10 days back. On examination, his pulse is around 110 per minute. Blood pressure is 100/70. Hemoglobin is 9.1. Total leukocyte is normal, and his creatinine is around 1.3 milligrams per cent. That's the ultrasound with the Doppler. And your question is, what are the 6 important complications of PCNL? Enumerate 6 important complications of PCNL. The next question, what is the classification system used to describe complications? What is the classification system we use to describe complications? The next question, what is the next investigation in this case that you would like to do? What is your most probable diagnosis in this case? There are 2 parts. What is the next investigation in this case? And what is your most probable diagnosis in this case? And mention any 4 principles to manage this patient. Now mention 4 principles to manage this patient. This carries 2 marks. Carries a total of 8 marks. All the 4 questions carry 8 marks. Moving on, let's get on to the 12th scenario. A 36-year-old gentleman presents with history of right loin pain for 5 days. And that's your X-ray KUB and your ultrasound. Look at the images carefully. And the question here is, mention 6 differential diagnoses after viewing these images. 6 differential diagnoses after viewing these images. And further evaluation, look at these images of CT and a reconstruction along with a CT film which is in form of a video. That gives you a better picture. Watch the images carefully. Okay. So what is the classification of Ureterocele? What is the classification of Ureterocele? What are the treatment options in this case? What are all the treatment options you have to treat this case? 2 marks. This carries a total of 7 marks. Thank you,
Dr.
and
Deepak.
thank you.
Thank you. Over to Dr.
Thank you.
Sishan.
Thank you, Dr. Deepak and Dr. Arvind Ganpule. So now we move on to the next OSCE, which is number 13. We have a case scenario. You can see the CT images here and the 3D reconstruction. So the questions are, what are the treatment options? So what are the treatment options for these stones? It carries 2 marks. Mention any 2 newer modalities available for faster and efficacious stone clearance in PCNL. This also carries 2 marks.
Sishan will give 40 seconds for this OSCE because we have shown the questions together.
Okay. So the total marks here is 4. So the next question is OSCE number 14. So there's a case scenario where you have a 71-year gentleman without any comorbidities who had complaints of lower urinary tract symptoms, which is poor stream, urgency, and frequency since last 2 years. And he also had complaints of lower abdominal pain since last 6 months. On examination, per rectal examination, which is digital rectal examination, showed grade 3 prostate. His hemoglobin was normal, total counts was normal, urine routine was also normal, serum creatinine was 1.09, and serum PSA was 3.9 nanogram. You can see the X-ray KV here. So this is the uroflow reading where he had a Qmax of 6.2 ml per second. The total voided volume was 177 ml and the average flow was 1.9 ml per second. This is the CT image of the same patient. So the first question is, what is the complete diagnosis? So you need to write the complete diagnosis here and it carries 2 marks. And what are the treatment options here for these conditions? So the next question is, what are the treatment options? And you have 2 marks for this. The total allotted marks are 4. So this is the last question of today's OSCE program. We have an 85-year-old gentleman with history of hypertension. He came with symptoms of obstructive lower urinary tract symptoms since 2 years. He was on medical management with alpha blockers. His international prostatic symptom score was 28 out of 35. He also had a history of acute urinary retention 1 month ago, and he was catheterized elsewhere. On evaluation, his serum PSA was 9.47 nanogram and a prostate size of 190 cc on ultrasound. This is a short video showing the procedure being done. Basically, it was a HoLEP which was done for this patient. That's the first part where you have the enucleation, and now you can see the second part. And it's obvious that it's a morcellation which is being shown here. Here you can see perivesical fat, and which is seen clearly from bladder mucosa when you're morcellating the prostate. So the first question here is, enumerate 4 principles of morcellation. You have to write down the 4 principles of morcellation, and this carries 2 marks. And the second question is, how do you treat an extraperitoneal or an intraperitoneal bladder perforation during morcellation? This question has 2 parts. So you have to write about how do you treat extraperitoneal perforation separately and how do you treat an intraperitoneal bladder perforation. That is during morcellation. And this has 2 marks. Thank you all, and I hope you guys have done really well. Move on to, now I ask Dr. Arvind Ganpule to take over this session.
Thank you very much, Dr. Zishan, Dr. Harpreet, Dr. Deepak, and Dr. Rahul. All of you must have written down your responses on the piece of paper. Now is the most important thing, that you have to scan your paper, photograph them, and send it on the address which has been mentioned in the chat box. You have to do this thing within the next 10 minutes. Right now it is 10:47, so you have to send it before 10:57. Arun Chawla, sir, you want to say anything, sir?
Dr. Keshav, we have kept our mailbox open. I think 10:57 will keep the lock-in time for receiving the responses. After that, will not accept. Is it okay, sir?
Yeah, 11. I think 11 o'clock should be all right. 11 o'clock. After 11, if the mail comes after 11 o'clock, we'll not consider.
Will not consider it. Okay, right, sir. Thank you, sir. And Dr. Keshav, how to make this time useful for the members who are not doing anything? Shall we have?
Yeah, I think Arvind must have planned to give a small talk. He can go ahead with that so that we don't waste time in that 10 minutes.
So for the members who are not engaged in the responses or the OSCEs, Dr. Arvind will take us to the journey into the bylines of the history of the PCNL. And I think it will be very useful for all of us. Over to you, Arvind.
Thank you very much, sir. Actually, this thought occurred to Professor Chawla yesterday evening, and he just told me to prepare a short presentation, which would be helpful and very interesting as well. So I hope that it would be interesting to everybody. What I thought of, that we'll go into the history of PCNL with a few snippets and go into the bylines of the art of EndoUrology was developed. So what I would be talking is about the birth of EndoUrology from 1975 to 1985. So those were the formative or a gestational stage for the subspecialty of EndoUrology, on which the basis on which our forefathers built the subspecialty. I would start with a small 3-slide talk on some less known faces and their contribution to the development of art of PCNL. I named it as the European connection. We all have heard of the Ambas dilator, but while researching for this particular thing, I was surprised to know that Kurt Ambas was an Austrian interventional radiologist. Was in fact nowhere related to urology at all. He was an interventional radiologist, and he was actually involved in making balloon dilators or development of devices which used to occlude ASD in the heart. So he had formed a company by the name AGA Medicals, and that was his claim to fame. He was known to be a serial innovator. But he came in contact with the father of EndoUrology, Dr. Arthur Smith, and in collaboration with Dr. Smith, this particular interventional radiologist and medical inventor went on to develop numerous innovations. I think that dilatation is quite synonymous, and many even wires are synonymous to this name, Dr. Kurt Amplas. It is very interesting to note as well that Dr. Kurt Amplas was a philanthropist by heart. If you go into the Wikipedia, you will be sweetly surprised to know that he donated $1 billion through the way of the monies that he got from the development of the device to occlude ASD for the medical treatment of poor. So this was something very interesting about Kurt Amplas, the same person who has invented the Amplas dilators for PCNL. The next, a little bit lesser known personality was Dr. John Wickham. He was a British urologist. Again, interestingly, actually, he was the first person who used the Pro robot. So we can say that he was known to be the first advocate of robotic surgery way back in 1980s. Dr. Wickham described the initial procedure of PCNL, and actually, many of you might be knowing that this was actually the first PCNL that was conducted on this side of the Atlantic. What he did that after placement of a small caliber nephrostomy tube, the tract was serially dilated over several days from 22 French to 26 French over a period of say 20 days or something. And after that, he had got a cystoscope that was 21 French, and he used to access the calyceal system. I think this particular innovation went a long way in development of the art of PCNL on this side of the Atlantic. An interesting snippet here is also that Dr. John Wickham was known to invent this word minimally invasive surgery because he was an avid follower and was very much interested in robotic surgery. He passed away in 2017 and was working at St. Bartholomew's Hospital in UK. All the Indian urologists are very well versed with Professor Peter Alkane, as he's a frequent visitor to the Urological Society of India conferences. He's a German urologist, and significantly in 1984 at the Second World Congress on Percutaneous Renal Surgery in Mainz, West Germany at that time, more than 3,000 cases of PCNL were presented, and he was actually the organizer of this conference, and the success rate at that time exceeded 90%. His claim to fame as far as the art of PCNL goes is that we all know about his telescopic dilators known as Alkane dilators, as well as the Alkane needle. So let's go to the other side of the Atlantic, that is across the Atlantic, to the fathers of endourology. We all know Professor Arthur Smith. Dr. Arthur Smith is the chairman emeritus at the Arthur Smith Institute of Urology at Long Island Jewish Medical Center at New York. To give his short history, actually, basically, he's a South African and immigrated to the US in 1977 and was appointed to the staff of Veterans Administration Hospital in Minneapolis. After that, he worked with Dr. Bob Miller. So as we must have heard in many of his talks which he had delivered in USI, that apart from Kurt Amplas, who was an interventional radiologist, Dr. Bob Miller was also an interventional radiologist, and these two were actually instrumental in igniting the fire of endourology in this tower. One of his first cases, as far as endourology goes, were antegrade stenting, that too for an ureteric reimplantation, because we all know that stenting in an reimplanted ureter is very difficult. So he chose his first case as an antegrade stenting, wherein he could pass and degestent antegrade. There was a little bit controversy as to what should be the first name of this new specialty. So there was a lot of discussion between Dr. Fraley, who was the chairman of Veterans Administration Hospital in Minneapolis, with Dr. Arthur Smith. Dr. Arthur Smith is known to have coined the term, along with Dr. Gopal Ballani and Dr. Ralph Clayman, the word endourology, the word we very commonly use nowadays. He defined endourology as the closed manipulation of the genitourinary tract. And this resulted in a poster presentation. This coining or birth of word endourology resulted in a poster presentation in 1978 at the AUA. And that poster was titled as Endourology, which actually his residents at that time privately retitled in humor as End of Urology, as they cited that as he was a very avid enthusiast of endourology. the chance of them getting open surgery drastically went up. So in humor, they had retitled this particular branch as End of Urology. But the results and his foresight is for all of us to see. Dr. Arthur Smith in 1982 accepted the position of Chairman of Urology at LIJ in New York. In 1983, he was the founder of the EndoUrology Society with Dr. Joe Segura, Dr. Ralph Lehman, and Gopal Badlani. And significantly, he was the president of the society for the first 25 years from 1983 to 2004. He is often referred to as the father of EndoUrology. He has got 550 PubMed index publications to his credit and many chapters and more than 150 index publications on the art of EndoUrology. We all know that this is the Bible of EndoUrology, Dr. Smith's textbook of EndoUrology, which is a recognized major text on this subject. Dr. Arthur Smith remains active even today at this age at the Arthur Smith Institute of Urology. As Dr. Arthur Smith is a very good friend of my mentor, Professor Mahesh Desai, I had got the honor and privilege of interacting with him many times. And a few things which he used to tell Professor Mahesh Desai, I like to quote it here. Once he was asked that why he used the 30 French amplas first. His answer was that I had got nothing better at that time, and hence I used an 30 French amplas. So you can see that how much we have progressed over the past 4 decades from an 30 French amplas to 4.5 French conduit, which is used for a microperk. And the second famous aphorism from Dr. Arthur Smith, which I have heard narrating to Professor Mahesh Desai, is that he always says that I am yet to find a stone which cannot be treated with endourologic techniques. So this is something about Professor Arthur Smith. The next person is Dr. Ralph Lehman. He is the distinguished professor and the endowed chair in endourology, Dean Emeritus at the University of California, Irvine. He is a graduate of UC San Diego. And very significantly, after his initial residency at the University of Minnesota, he became a resident with the father of endourology, Dr. Arthur Smith. And this is very interesting. During his residency, he has mentioned in his autobiography that he and his colleagues would hide some of his renal stone patients from Dr. Arthur Smith during the rounds so that open surgeries could be performed on the patients and not endourology. In 1984, he initiated the first fellowship program in endourology, and till date, he remains one of the co-directors at UC Irvine for the Endourology Society fellowship programs. Significantly, apart from PCNL, he is also known for his work on laparoscopy. He initially did the first laparoscopic nephrectomy on porcine kidneys, and then he's credited with the first laparoscopic removal of kidney in an 85-year-old woman in 1990. He remains to be the chair of urology at the Department of Urology at UC Irvine. He is the co-founder of the EndoUrology Society with Dr. Badlani, Dr. Joe Segura, and Dr. Arthur Smith, and continues to serve as the founding co-editor of the Journal of EndoUrology. He holds numerous patents. Offhand, I know that he has got more than 100 patents in the art of minimally invasive surgery and more than 400 peer-reviewed manuscripts. And he's, as I told, he's currently the chair, the co-chair of the EndoUrology Society Fellowship Program. We all know that he's a very articulate orator, and one really gets glued to the screen whenever Dr. Arthur Smith is talking. So it is famously known as the Clayman Doctrine, and he gives these 5 thumb rules. He says that these are the principles of life. Always work harder than anybody else. Nothing good is easy. You are only as good as your worst error. It takes very little from being good to being excellent, and what you are doing should be fun. I think majority of our participants today are residents, and this Clayman Doctrine should be there in their classrooms or operating rooms because they will be acting as an inspirational quotes for all of them. Finally, before I conclude, I would like to give a few words on the history of EndoUrology Society and the Journal of EndoUrology. The EndoUrology Society was founded after 3 successful annual meetings held in London 1982, Germany in 1983, and US in New York in 1984 under the umbrella of Dr. Joe Segura, Ralph Lehman, Gopal Badlani, and Dr. Arthur Smith. This is a non-profit organization with international faculties with a reach world over. The society was officially instituted in May 1st, 1984 and incorporated in 1985. The logo or the first page of the journal always mentions that the ambit of endourology includes closed manipulation of the genitourinary tract. So for this society, even robotic surgery, laparoscopic surgery, and endourologic manipulations for stone also is included in endourology. The first president of the society were Dr. Smith, secretary were Dr. Ralph Lehman, and Gopal Vadlani was the treasurer. This is very interesting that the first official newsletter of Endourology Society was titled the EndoUrology Newsletter, and this was circulated during the World Congress of Endourology in New York in 1984. And to the surprise of all of them, it was met with enthusiasm, and this gave birth to this journal, which I offhand know that the impact factor exceeds 2 as of now. In 1987, the newsletter was replaced by the Journal of Endourology, a monthly peer-reviewed publication with Arthur Smith as the editor and Ralph Lehman as the co-editor. So these were the small snippets going into the bylines of the art of endourology, and I hope it is useful for all the participants. Over to you, Professor Chawla, Professor Keshavamurthy. So can we...
Arvind, I think it is time now that we go on to the second part of this. We start giving answers to the OSCE.
Okay.
Dr. Keshav, we lock in the time now? It's
Yeah, we lock in the time now.
Okay, fine then.
Go ahead, Dr. Arvind.
Yes, sir. So now what we are going to do in the same sequence as we had given the, we are showing the questions in the same sequence, we will be giving the responses. So the 3 questions that I showed, I will be giving the responses to them, and accordingly Harpreet, then Rahul, Deepak and Zishan will be giving the responses. So we go to the first question. So I will first go through the case scenario and then give the answer. So this was the case of an lower calyceal stone and 17 millimeter stone in the lower calyx. And these were the questions, the treatment options we had asked, that which are the 3 most preferred treatment options for this particular stone. As you know that this particular patient underwent an ESWL. The logic behind giving ESWL might be questionable. From the examination findings, all of you will agree that this patient was pale on presentation. He had got tachycardia, and if you see that there was a significant drop of hemoglobin with a rising creatinine. I'm sure that most of you must have noticed in this CT scan image here that the right side kidney is comparatively smaller. So you can understand that this was a solitary functioning kidney, and after that, following the ESWL, the patient had developed an subcapsular hematoma. So this is something that we wanted to highlight, that whenever you see the images, you have to always see what is happening to the opposite side kidney. These were the 3 questions that we had asked. What is the most likely diagnosis? Mention 2 causes for patient's deranged renal function, and mention 4 principles for the management of this case. And these were the 3 general questions to assess your general knowledge on the modality of ESWL regarding complications, mechanism, and risk reduction strategies. So we straightway go to the answers, and the way in which you are going to, this would be the key that would be passed on to the ISU USI office, and accordingly your papers will be assessed. So for the first question, according to the EAU guidelines, what are the 3 preferred treatment options? 1 mark for each option. Actually, there is a small error here. I have changed it in the key. So ESWL, RRS, PCNL. So each of these options will have 1 mark each. So if you have written only ESWL, you will have 1 mark. Only RRS, 1 mark. Only PCNL, 1 mark. So a total of 3 marks. The second question was, what is the most likely diagnosis? A total of 2 marks. I have given 2 options. That is. First option is subcapsular hematoma with sepsis, and the second option is page kidney with sepsis. If the candidate writes any one of these, then he will get 2 marks. It's not necessary that we will get stuck on the word of page kidney or a subcapsular hematoma. Even though if you write either subcapsular hematoma with sepsis or page kidney with sepsis, you will get 2 marks. The next question is, mention 2 possible causes for deranged renal function, a total of 2 marks. Any 2 responses out of these will get 2 marks. The options are pre-renal acute kidney injury, obstructed stones leading to sepsis, medical causes such as hypertension, drugs, and obstructed stones. So if you have any of these 2 response, you'll get 2 marks. Mention 4 principles to further manage this case, a total of 2 marks, 0.5 marks for each response, and the responses would be resuscitate the patient, antibiotics, blood transfusion, and first USG guided left drain placement. So going to the next question, as regards the 5 complications that we wanted from that happen after ESWL, apart from Steinstrass. And the second part of the question was, what is the incidence of Steinstrass after ESWL, a total of 3 marks. So each of the complications will have 0.5 marks and the incidence of Steinstrass would be 0.5 marks. And we will consider this particular table. If you write anything between 4 to 7%, it will be considered correct. And these would be complications that we have enumerated that we would be considering whenever you are going to give your response. The next question was, enumerate any 4 principal mechanisms by which stones are disintegrated by ESWL. Any 4 response, because there are a total of 2 marks, and each response will carry 0.5 marks, and the answers could be spale fracture, squeezing, shear stress, superfocusing, acoustic cavitation, and dynamic fatigue. So if you give any 4 responses, you will get all the 2 marks. Going to the next question, enumerate any 4 risk reduction strategies to reduce complications in ESWL. Each response will have 0.5 marks. Any 4 responses would be okay to get 2 marks. And the answers could be general anesthesia to reduce stone motion, slow frequency, that is reduce the rate of shocks. It improves fragmentation and decreases renal damage. You can sequentially ramp up the power. Careful monitoring by USG or fluoroscopy. Pre-ESWL stenting reduces incidence of Steinstrass. Proper analgesia during therapy reduces respiratory motions. So those were the answers or the key that we have for the OSCE 1. This was the next case. Basically, this was a case wherein you see multiple small stones which were distributed in all different peripheral calyces. In almost each calyce, you can see the stone. An important finding here was that the serum calcium was 11.5. The questions that we had asked were, what is MSK? What are the characteristic findings on IVU and CTIVU? Mention any 2 differential diagnoses you would think of in this case. Enumerate any 6 indications of metabolic evaluation. Name any 4 methods of commonly used stone analysis techniques. We wanted biochemical and imaging techniques for imaging hypercalcemia. And finally, 4 main principles for treating acute hypercalcemia. So these are the this is the key to the questions. Enumerate 6 indications of metabolic evaluation for stone, 3 marks, 0.5 marks for each response. Any 6 of these responses will fetch 3 marks. And I think this is relatively very common: recurrent stone formers, strong family history, strong intestinal history, family history, history of urinary tract infections with calculi recurrent, history of gout, solitary kidney, anatomic abnormalities, renal insufficiency, patients having cystine, uric acid, or sphygmoid stone in the past interventions, and all children. So among these 11, any of 6 that you give, you'll get all the 3 marks. What is MSK and what is the characteristic findings on IVU or CTIVU? So although this is a bit descriptive, what we want is that we want the word tubular dilatation of the distal portion of the collecting system. If you get this word, then I think you know the concepts and the foundation of what we wanted to ask about MSK. And in the second part, the characteristic findings, we would prefer to see these words, bristle on the brush or bouquet of flowers, which often refers to more ectatic and filled tubular dilatation with calcification. So these are the key words that we would be looking for whenever we will be looking into the questions. The next question was, name any 4 methods of stone analysis available. 2 marks, 0.5 marks for any of these response, any of these 4 response. Any of these 6 responses: chemical analysis, thermogravity, gravimetric analysis, polarization, microscopy, SEM, powder X-ray diffraction, spectroscopy. So if you write any 4, it is fair enough that you get 2 marks. The next question was, how will you investigate underlying condition in the case of hypercalcemia? So we wanted these 4 answers: serum albumin level for corrected calcium levels, serum PTH, ultrasound neck for any adenoma or parathyroid gland or hyperplasia, and system AB scan to confirm it. Among the principles that we wanted, this question was for 2 marks, 0.5 marks for each response, and we wanted any 4 out of these 5 options. First was hydration with normal saline, forced diuresis with Lasix to create hypercalciuria if concurrent CHF is there, biphosphonates or denosumab. Calcitonin can be given, and hemodialysis as a last resort. Not necessarily that your answer should come in the same sequence, but as long as you give any of these 4 answers, it is fair enough. The question regarding the differential diagnosis in that case, it carried a total of 2 marks, and the answer that we wanted was renal medullary calcinosis, MSK, and renal tubular acidosis. Coming to the third question, this particular case was about this lower calyx stone, and she had presented with left flank pain since 2 days. And we had given all the imaging investigation, which included CT IVU, as well as because we wanted to highlight the importance of Hounsfield unit, which was 1239 on the CT IVU. And the questions that we were asked were very specific about what does the EAU guidelines say as far as the imaging modality is concerned. The next question was about the importance of Hounsfield unit, followed by the 3 treatment options as per the EAU guidelines, and the 4 important relevant factors for as far as lower calyceal anatomy is concerned. And mind you that this question was not very specific to ESWL. It might be for RRS, ESWL, or whatever PCNL. So what is the ideal imaging modality of choice as per EAU guidelines? Any of this answer would be acceptable, CT IVU or NCCT, because there is a little bit ambiguity, because NCCT is a treatment or imaging modality of choice whenever there is a colic. And the guidelines are very ambiguous as far as the CT IVU is concerned. So we'll accept any of these 2 answers if they are given. Mention 2 significant points as regards HU of a stone, which can help in management. So 1 mark if you talk something about stone composition, and 1 mark if you talk something about treatment planning, like less than 900 ESWL done, more than 900 consider PCNL or RRS. As regards the third question, what are the treatment options as per, again, very specific EAU guidelines in this case? So if all are answered, you get 1 mark. If 1 is answered, either 0.33, 0.33 or 0.34 marks will be given. The final question for this OSCE were that name 4 points relevant to the lower calyceal anatomy with bearing on treatment outcomes. A total of 2 marks were allotted for this question. And these 5 points we wanted to hear from you. Which relate to the dependent calyx, infundibular pelvic angle, infundibular width, infundibular diameter, and the infundibular length. So 0.5 marks each, any 4 responses. Harpreet, over to you.
Thanks, Arvind. Good morning, everyone. Once again, good morning, Mahesh Desai sir. Mine is much simpler than what Arvind has presented. So I have seen this 45-year-old male presented with right flank pain. And the questions were, so you have to mention the 3 findings on the imaging. I'm sure you all have seen this big renal stone, and you have also seen this IVB pictures and absent kidney also. I'm sure. Arvind, can we go to the answers part? Or yeah. So we have these 3 important imaging. I know you all have done correct. This renal calculus, right pH obstruction, and left kidney not visualized, suggestive of left atrophic or absent kidney. I'm sure you all have done this. This is an easy one. So treatment options are also easy. Laparoscopic or open pyeloplasty with lap pyelorthotomy, or right PCNL followed by right pyeloplasty or endopylotomy. It's not that we advocate this, but this can be one of this in a lower down this treatment modality. But yes, the first one is the right treatment modality. Coming to the 3 radiolucent stones other than uric acid stone, I know you all have done good. Ammonium urate, xanthine, 2,8 dihydroxyadenine or adenine stones. You know this all purine metabolism. Then the drug stones, right? Indinavir and all. So we are, because our last question was here. One is formula they use is ICU, Indinavir, and then cystine stones and urate stone. That's the one formula for radiolucent stones. Name 2 stones which are not seen on CT and X-ray. So you have Inanamid, protease inhibitor. You know, these are the drugs we use in the retroviral drugs, and this for virus, HIV treatment, and the pure metric stone. I'm sure these are very common ones, so you are done good on this. Next question, Avi. So coming to question 5, this is a very good one. You have seen this big, large stone, I'm sure, and we asked you the stone scoring systems, giving the size and how to proceed, and what are the composition of the stone and the bacteria producing urease other than protease. Coming to answers. So you all know about this Guy's stone score system, stone score, Crow's nomogram, Staghorn morphometry, and the Seoul National University scoring system for this complexity of the stones. So you know about the controversies, you know each help to some extent. There are a lot of comparisons also available on the literature. If for whatever 4 you have given, we'll get the full marks. This is just to enumerate what are the systems available for the scoring systems for the stone. What is the next investigation? We have asked after showing that KUB, you have to tell us clinician would like to know. So CT IVU or IVU is also correct, because CT IVU will give you the Hounsfield unit. It can give you the functioning. IVU can also give you the functioning. Cholesterol anatomy can also be seen in the IVU, as well as the density of the stone. So CT will give you definitely a little more option than others. Then coming to the third question, what is the most likely composition of this stone? And so struvite stones, which we also in a short form CAMP, calcium, ammonium, magnesium, phosphorus stone, a triple phosphate CAMP, PCNL, to remember it. Infection stone, urease producing stones, cystine stone, uric acid stones. So whatever you have written, if any one 4 of this will get you a good full marks. And coming to the 4 bacteria producing urease other than protease, you know, as this protease splitting bacteria, the urease enzyme which splits urea, it produces ammonia, bicarbonate, and carbonates. So ABC we used to remember that way, and these are more of the ammonia is produced. That's the reason you get this infective stones. Providentia is basically the opportunistic infection seen more in patients with catheters. Klebsiella pseudomonas, you know, I know, Staphylococcus, Mycoplasma, and Uroplasma erotica, other organisms. So any 4 of this give you a good full marks. Next question, Arvind. So coming to question number 6. This was very interesting. Arvind has made it very, very interesting by giving a twist to this history of 65-year-old man with a obstructed LUTS and with a large prostate. So I'm sure you have seen this ascending urethrogram. You can see these 2 narrowings. These are shown very nicely, and I'm sure you have written this answer, as well as the lifting of the bladder base. I'm sure you all have noticed this and have mentioned in your answer sheet. Coming to answers, Arvind, next slide. Yeah. So inspection, as you know, we are looking for BXO. You have to see the meatus. It is tenuous. It is scarred. Phimosis. Sometimes we see simple phimosis. Then the palpation may reveal spongiofibrosis. You have to palpate. You can feel the nodulity of the urethra. Then DRE examination of the prostate. Sometimes in a traumatic injury, the prostate may be very high, or you will not feel it. And moreover, also look for SPC scars. There may be history. This patient have undergone earlier stricture surgery. SPC scar. Look for perineal scars. So all these 4s are good, but this is just to add to it. Then I as mentioned findings on ascending urethrogram. You have seen the sphenocortal junction narrowing and the proximal valvular stricture and enlarged prostate. So if you've written this, you're getting full marks. And what are the treatment options available in this patient? So erythrocystoscopy will give you the tell you about the stricture. We can do balance dilatation, you can do visual internal erythrotomy, and you can assess the prostatic enlargement and maybe TURP. Or second procedure is urethroplasty for TURP. All these answers are correct. As you know, RGU and MCG are needed to know the location, length of the stricture. But sometimes in equivocal case, urethroskopy do help us actually to identify the stricture. And this one, the question, what are the recurrence rates after primary Western internal erythrotomy and the secondary? So the primary one is 66 to 90% at 1 year, and second one is 40 to 60% at 2 years. Coming to the biological modifiers, as you know now, as our knowledge is every day changing, we are finding that there are methods other than surgery which can help us to prevent or dissolve. So keeping that in mind, name 3 biological modifiers to prevent stricture. So the 3 responses: steroids, FOX2 inhibitors, mitomycin C, captopril gel, hyaluronic acid, botox, rapamycin. Tacrolimus was very, tacrolimus ointments are available. We do ask patient to put it. People do have presented papers. So this is all to sum up in shortly my answers. Thank you, Arvind, for giving me this opportunity. Thank you, USI. Over to Rahul. Rahul?
Rahul? Oh, Rahul is there? Okay, he's not there. Okay, then if he's not there, I will continue. No problem. So this was this question was, he was a 75-year-old diabetic. He presented with history of LUTS for 1 year, and it aggravated in the past 3 months. You can see that he mainly had got frequency of micturition and poor stream, no history of urethral intervention in the past, and he had got a palpable bladder. So the questions, the first 2 questions were related to the components of the IPSS score. And the second question, we wanted to know what is the difference between the AUA score and the IPSS score. And then a few questions about the indications of urodynamics, Abraham-Griffiths number, and any 4 newer invasive modalities in the treatment of LUTS. That's what we wanted. Subsection or subpart of this question was these were these urodynamic tracings, and we wanted you to write 4 important findings seen on this UDM. Jumping straightway to the answers. What are the components of IPSS score? You all know that the components are frequency, urgency, nocturia, intermittency, poor stream, straining, incomplete emptying, and quality of life. As far as the difference in AUA score and the IPSS score goes, the quality of life is not included in the AUA score. The indications for urodynamics while investigating the male LUTS are any of these 4 would fetch you marks. Men who had previous unsuccessful treatment for LUTS, patients who cannot void more than 150 ml, when considering surgery in men with bothersome symptoms and a PVR of more than 30, and a very young patient or a very old patient. So these could be the answers that we could give. As far as the AG number is concerned, it is the Abraham-Griffith number, and this is the formula. We are looking for these newer minimally invasive modalities in the treatment of LUTS: Prostatic, aquablation, vapor therapy, PRX 302 protoxin injection, intraprostatic NX 1207, histotripsy, and botulinum toxin injection. If you go back into the tracing of the urodynamic, I'll just go back. You'll see that the patient has voided with an high pudate Qmax. The pudate Qmax is exceeding 67. Otherwise, he's having a good proprioception, and he is having a good bladder capacity. And you can see that the nomogram is showing that it is within the obstructed range. So out of this, but we have enumerated these 7 or 8 findings that we see on the urodynamics, and any 6 of these will get you a response of 0.5 marks. I think Dr. Rahul's connectivity has come back.
Sorry.
Yes,
Rahul, you can go ahead. Thank you for covering me. Question number 8. Can I have the question again? The instruments form a very important part of our daily routine, and I've seen a lot of times that the candidates don't take a lot of care in seeing these instruments, because they are given already cooked up things. The sister in charge or the person who is scrubbing with them would keep everything ready, and they would just come and do it. My feeling is that once you are by your own, if you're not into an institute, and a lot of us don't get that opportunity to work in an institute and work alone, then we should always be knowing of all our instruments. So in my institute, where my DNB resident is there, I always ensure that they assemble and disassemble the things themselves. So this was a straightforward thing for anybody who's doing their work their own self. So they can just identify that. Each instrument, the first instrument, the answer, I'll just come to the answers. Can we have the answers? Yeah, each instrument is a standard cutting loop, Collins Life, and a ball electrode. So there is nothing much in this. Anybody would who's doing his work himself would know that. Describing each instrument is that it's a standard cutting loop. The standard loops are useful for transurethral resection of prostate. Even for TUR BTs, we can use them. So whereas the surgery for the prostatic adenoma demands the almost exclusive use of a thicker loop, whereas a thin loop can be used for TUR BTs. Thicker loop because they cut and coagulate very nicely. Collins knife is a very useful instrument. Anybody who's passing out and should have one Collins knife in his kitty, if not more than one, because it is used to incise the bladder necks, do a TUIP. Not even that, the incision is, they can use it for like what the answers for the broken loop. If you don't have a Collins knife, you can use a broken loop as a Collins knife for itself, or incising a ureterocele or impacted low ureter calculus, which is a lot of edema is there. You can incise on that and deliver that stone out into the bladder and do the needful. Similarly, ball electrode, it's a very simple and a basic instrument. It is used for achieving hemostasis after any transurethral surgery, whatever we have done. What are the uses of broken loops? It can be used to active arm is connected for ureter metotomy, as I already said. And if your Collins knife is not working on that particular day, or you don't have one, and suddenly you have posted a patient for a TURP, you find that the prostate is very small or a bladder neck is high, you can do an incision with the broken loop. Posterior urethral valves can also be, if you have a pediatric scope, you can use for that also. So anybody who has answered the questions would get the marks. It's a straightforward question and straightforward marks, more of an arithmetic thing. So last question was from my side was, again, this coming to the instruments. They're very important instruments, and everybody should know about them. The name of the instruments, can I come to the answers? It is one is a straight obturator, leash obturator. It is if somebody writes a straight obturator, it is acceptable. A lot of people use that, and the companies often give only this straight obturator with the basic endoscopic instruments. Then is a Timberlake obturator, which is very important for high bladder necks, in which there is a large prostate is there and you want to negotiate that prostatic curve. It's a very good instrument, and if you have it, it is always an asset to you. I would suggest that anybody who is passing out should have one of this thing, because once you need that, the day you will need it, you will really be very thankful that you had it with you. The third is a viewing obturator. It is again, this is not a very standard instrument given by the companies, but if you have it, it is always good, especially if you are doing, you have put in a scope and you're not very sure where you are, or if there is, some inadvertent injury to the bladder, or sorry, to the urethra, and it is oozing and it is red. So you always have a visual obturators. You can find the normal passage and get into the bladder or your field of interest. According to the second, the marks according to the metal straight obturator, it is closed, it is smooth, and the vesical end is smooth and sheath and helps the instrument to get in. And you should not be introducing any other than a cystoscope, any resectoscope or OIU sheath without an obturator into the urethra. It snugly fits into the sheath and helps in the atraumatic insertion of the instrument, which is very important, because if somebody develops iatrogenic injury to the urethra, to me it is a very unacceptable thing, because stricture is incurable disease in my books. Hinged obturator, again, as I said, it helps for the blind insertion of the instruments, particularly in obstructing medial lobes. And the last but not the least, the viewing obturator, that's the Smith's obturator. It helps in the introduction of the sheath under direct vision. As far as possible, we should teach our residents to introduce the instrument this way till they really get a lot of experience in putting it blindly. Thank you, Arvind, and sorry for the glitch initially.
Yeah,
I think
thank you very much, Rahul.
Thank you.
Thank you, Rahul. So over to you, Deepak.
Yes, sir. Now, taking forward to the answers, the first scenario I presented was 55-year-old diabetic male. Now, it's about a tender prostate and Bogginess there. We are primarily talking about prostatic abscess. So I'll take you through the answers that what we are expecting from you. And there were three parts in the questions that we have put forth. And the first one being, what is your most probable diagnosis and the predisposing cause? So it's a straightforward answer, a prostatic abscess, that gives you a mark. And the second part of the question was about predisposing causes. And most common ones, yes, the immunocompromised status is one of the most commonly given answers. Diabetes is most profound in our society. And of course, HIV is another answer. But here we are looking at diabetes and a bladder outlet obstruction, which is the most common cause for prostatic abscess. And also, I guess you would have read that chronic prostatitis is another element which we normally think of, which eventually becomes and presents into a prostatic abscess. And the second question was the investigation to be done at the outset to clinch the diagnosis. And there are two acceptable answers that we are looking for. One being transrectal ultrasound, and a transabdominal ultrasound is also acceptable. Uh, a small note here, remember, transrectal ultrasound might not be always possible, and the patient might not allow you to do it in acute scenarios and where it is quite tender. It's very, very painful. And hence, yes, either of these are acceptable as an answer. And the third part being, how will you treat this condition? It's into, there are 2 marks to this question that were allotted. And of course, all these patients predominantly are advised to get admitted, admission, antibiotics, IV antibiotics, control of diabetes, which becomes one of the major concerns here, and a truss-guided aspiration, transrectal ultrasound-guided aspiration of the abscess, or resection of the prostatic abscess. Either of these two, depending on the size of the prostatic abscess and the volume. So these are the 2 factors which you consider in, and then take a call whether you would like to aspirate or resect a prostatic abscess, something like just deroof the abscess. And coming to the next scenario which I presented, we are dealing with a 25-year-old male with history of hematuria post PCNL scenario. So we were looking to discuss the complications of PCNL, and we have put forth 4 questions here about the 6 important complications, the classification system, what would you do, the investigations to take the management further, and what are the principles of management of such patients. And coming to the answers that for these questions, the first one being the 6 important complications of PCNL. And we've given 3 marks for this, and of course, half a mark for each of the response you would give. We're looking at complications like sepsis and hemorrhage, the most common ones we normally term, along with the surrounding organ injury or the neighbor organ injury like colon or pleura, a persistent leak, urinary leak, a renal pelvic injury during the surgery, and of course, death being one of the grave complications. So that would fetch you 3 marks. And in complications per se, yes, hemorrhage is one thing which we are all worried about. Just to highlight, I guess bleeding is the complication which we keep discussing in PCNLs. And one point I would like to make out here is where would you choose your puncture, and that would determine the bleeding percentages also. For theoretical purpose, I guess subcostal punctures are the least, which leads to bleeding. I guess it's less than 1%. And the moment you go above the 12th rib, it goes up to 5%. And if you go above 11th rib, that's when it touches almost 20-25%. And coming to the classification system, we are trying to ask which is the one we normally assess. It's nothing but modified Clavian-Lindo classification. That's a straight 1 mark there. And what is the next investigation that we are looking at, and what is your most probable diagnosis? There are 2 parts to this. The investigation that we're looking at to deal with, especially delayed complications like bleeding, is we're trying to look at the vasculature. So renal angiography becomes the investigation of choice, which will fetch you a mark. And the most probable diagnosis, like we're looking at, is an iatrogenic AV fistula or a pseudoaneurysm in segmental artery. Mind you, this is the most important complication that should be hitting your brains if it is 10 days post surgery. And the immediate complications are very much picked up when the patient is in the hospital. But remember, when the patient comes back with this kind of a scenario, then you look at these terms. And mention any 4 principles to manage this patient. We want to know the principles of management, and split into 2 marks. And that would be admission, of course, for resuscitation, IV fluids, angioembolization with coils. And of course, once you do angiography, you would get to pick up and know the details, and then you embolize it. Blood transfusion becomes important because of a significant hemoglobin drop, and absolute bed rest. And coming to the last scenario, which I presented, is about a 36-year-old gentleman, and we showed you these couple of radiographic images, one being an X-ray KUB and another ultrasound. We wanted to know the differential diagnosis viewing at these images. And the next slide is about reconstructive images and the CT pictures, which again further questions about classification of Ureterocele and the treatment options that are available. Coming to the answers, this is primarily about Ureteroceles and the stone that we have seen on the X-ray, which is beautifully picturized. That would be a cystoscopy video, which will give you insight about what we are looking at. There you go. So what is the differential diagnosis? In this case, we are looking at vesical calculus, a VUJ calculus, calculus in the diverticulum, stone in an orthotopic ureterocele, stone in an ectopic ureter, a stone in an ectopic ureterocele. So these are all the possible differential diagnoses we can look at. That cystoscopy beautifully enumerates the ureteric orifice opening. What is the classification of ureterocele? Clinically, we have always been taught that there are two primary ways of classifying. One is intravesical and the other one being an ectopic ureterocele. That defines the entire management principles. You can see the ureteric opening just beyond the verumontanum there. The intravesical ureterocele will fetch you a mark. Within that, a stenotic variant or a non-obstructive variant. Those are two which will give you half a mark each. And the ectopic ureteroceles, the most common one being sphincteric, which is 40% of the times, and sphincterostenotic, a sicoureterocele, and a blind ending one. These form the rest of the options. So together, between these classifications, I guess you'll have to give around 6 variants to get the 2 full marks. And the last question being, what are the treatment options in this case? An endoscopic ureterocele incision with the lithotripsy of the stone that which is quite large one. Either you use a laser or a lithoclast. The principle being to do the lithotripsy of the stone and as well as incise the ureterocele. That would complete the entire spectrum of questions. Thank you, Dr. Arvind, and I'll pass it on to Dr. Jishan to take forward.
Thank you, Dr. Deepak. Over to you, Zishan.
Hello. Thank you, Dr. Deepak. And moving on to the responses to the questions which were asked by me. The question number 13, this was fairly a simple question where we had shown you an X-ray and 3D reconstructed image of bilateral complete staghorn stones. And we had asked what are the treatment options and newer modalities for faster and efficacious stone clearance. So the answers here are, you can either go for a bilateral simultaneous lap pyelolithotomy or a staged lap pyelolithotomy or a staged open pyelolithotomy or a multi-stage, multi-tract bilateral PCNL, which may be either supine or prone depending on the expertise. So while I was going through the literature for this, there was an excellent article which was published in Journal of EndoUrology, which was pointing out the criteria for potential patient for initial bilateral simultaneous PCNL versus when to defer a contralateral surgery. As you all know, you can go for a bilateral simultaneous PCNL if there is a tailored approach, mutual agreement between the patient surgeon, and the patient has favorable calyceal anatomy and anticipated single tract procedure, or also when the patient has good performance status, normal function, and limited comorbidities. So here are the few criteria where you have to defer the contralateral surgery. This is just for your information. Apart from shared decision with the anesthetist, you have to think about deferring the procedure when there is an operative time of more than 180 minutes. This is just particular to PCNL. And when there is severe hemorrhage, there's a hemoglobin drop of 3 gram or a level less than 11 gram, arterial oxygen saturation less than 95%, when the systolic pressure goes down below 100 millimeter of mercury, and when there are multiple comorbidities, and of course, when there are unseen complications. So these are the criteria when you defer a bilateral simultaneous PCNL. So the other question, what we asked was, what are the newer modalities available for better and quick stone fragmentation and clearance in PCNL? As you all know, EndoUrology has undergone a lot of technical advancements and innovations. Now we have thulium fiber laser, which can go up to 2000 hertz, and it's one of the most powerful laser in the market. You have shock pulse, you have Radiology, which is nothing but pneumatic with ultrasonic and suction. These are the newer gadgets and instruments which can help you in faster stone clearance and operative time. So moving on to the next question. So the 14th question was regarding a 71-year gentleman who had complaints of poor stream urgency and frequency, and he had a normal PSA and a grade 3 prostate. So the clue here is in the CT image where you can see a large prostate and with a stone which is quite hard, which is quite dense and around 3 centimeter in size. So what we asked here, apart from this, by showing you a uroflow was the staccato pattern. That is nothing but a straining pattern here where the average flow was just 1.9 ml. So the question what we asked here was regarding the complete diagnosis and what are the treatment options. So the diagnosis is quite simple. You have a vesical calculus or a bladder calculus with prostatic enlargement. And the treatment options here are cystolithotripsy with prostatic evaluation and TURP, or an open prostatectomy with cystolithotomy. So you can go for a suprapubic or a transurethral cystolithotripsy depending on the size of the stone. And if it's a hard stone and a large stone, as you can see here, it's better to go with the suprapubic cystolithotripsy, sequentially dilate the bladder and keep an ampullus and break the stone and remove all the fragments, following which you can retain the suprapubic catheter and you can go for a TURP here. When you have a suprapubic catheter and you're doing a TURP, the chances of complications are quite less. TUR syndrome is reported to be very less when you're having a suprapubic catheter because that reduces the pressure inside the bladder, and also the TURP can go uneventful. And if you have decided for open prostatectomy, you can also remove the stone at the same time. Moving on to the next question. So this was the last question where we had a whole beam laser enucleation done for an 85-year gentleman with a prostate size of 190 cc and PSA of 9.47 and a normal PSA density. So the first video what we showed was a holmium laser enucleation. The enucleation part was uneventful, good hemostasis. Then when the morcellation started, initially it was going well, but then in between you can see there was a area of perforation where you could see the fat, perivesical fat, and some minimal bleeding was there. So the question what we asked here was the 4 principles of an effective morcellation and how do you treat extraperitoneal and intraperitoneal bladder perforation. So there was an excellent article which was written by one of our own faculty, Dr. Pankaj Maheshwari, regarding the basic principles of morcellation. It's one of the a well-written article which I've gone through, and he clearly says you have to constantly fill the bladder, make sure that you have your hand kept on the bladder, or ask an assistant to palpate the bladder throughout so that you can feel that the bladder is full. You can also increase the irrigation fluid to fill the bladder, because when you morcellate, morcellation has 2 parts. One is the suction and the other one is the blade. There are 2 5 mm rotating blades which keep on chipping the prostate, and the suction will keep taking the tissue in. So you have to make sure that the bladder is totally full, and before that you have to hemostase. You have to achieve complete hemostasis in the fossa. And always remember that if there is poor vision, if there is it's not clear, you can always postpone the morcellation part. There's no harm in leaving the prostate tissue inside, and you can go after 24 hours or 48 hours, and again you can morcellate the enucleated prostate. And make sure that the morcellator strip is always faced towards the dome at 12 o'clock position, and never ever go towards the trigone. It should be kept in the center of the bladder facing up at 12 o'clock and morcellate. Make sure that the bladder tissue is never held by the morcellator, otherwise you can have perforation. And another key important point which I would want to add is make sure when you have small tissue bits, don't try to morcellate it. When you have a small tissue bit, you can always use a Toomey syringe or Helix, or you can use a TUR loop to cut the tissue and take it out. Never ever go chasing the small tissues. And if you're unable to morcellate, it may be because of the blade. So you can change the blade and have a fresh blade to morcellate the tissue. So what are the treatment options for extraperitoneal and intraperitoneal perforation? This is quite simple. It's similar to the traumatic extraperitoneal or intraperitoneal perforation. If it is extraperitoneal, you place the catheter for a month, do a cystogram, and remove the catheter. It will heal on itself. You need not explore. And if you think there is an intraperitoneal perforation, then better to explore and repair the perforation. And you can place a SPC and urethral tube, and which can be removed after a month. So we have a couple of images of this patient where this patient was explored and there was a clear intraperitoneal perforation which was repaired in 2 layers, and afterwards a SPC was placed. Thank you all. I hope you all have done well.
Thank you very much, Zishan.
Thank you, sir.
With that, we come to the end of our second part of our OSCE program. I'm sure that most of you must have passed on their scanned images to the Gmail ID that we had given. Before I hand over the proceedings to Professor Chawla and Honorary Secretary Dr. Keshav Murthy, I would like to give my sincere thanks to all my colleagues in the EndoUrology cell. My special thanks to my colleague Dr. Rohan Batra for helping me in this. I would like to thank three people: Professor Rajiv Sood, Professor Arun Chawla, for his guidance and very critical assessment of the OSCE questions that I had drafted. And he was so critical about it that we had around 3 to 4 sessions before we could get on to the final thing. And of course, I would like to thank Professor Keshav Murthy for considering me worth this particular endeavor. And thank you all the participants for coming here in large number. We had got 172 participants at the peak. Over to you, Chawla sir and Keshav Murthy sir. Sood sir.
Thank you, Arvind. A very nicely scripted program, well-crafted OSCEs. I think it was like for the students a semi-final towards the preparation of their final exit exam of MCH and DNB. And if the radiants can note from the OSCEs, nice case scenarios built around the upper tract and the lower tract conditions, stones, BHP, strictures. We had, in addition to these case scenarios, operative surgery in the steps and the mentions of procedures like PCNL, the ESWL and the complications, the VIUs, the laser enucleation of the prostate and its complications. And while scripting this program, you can just make note of, we had operative urology as well as armamentarium also covered. We had various instruments in these sessions. We had uroradiology covered. You see the different CT, the IVUs, the ultrasound, and the Doppler of various condition kept. And you had a urodynamic tracing also, which made almost this endourology something like an excellent session. And to me, the icing on the cake was the presentation of the insight into the various legendaries involved in the journey of the PCNL, especially the couplets of Arthur Smith, as quoted by your mentor, Dr. Mahesh Desai, the Clayman doctrine, which was an excellent. I think not only the residents, everybody should have in their the hanging on their wall in the clinic or wherever they're working. Overall, well-scripted, well-attended program, more than 170 on the YouTube, 170 close to on the Zoom platform. With this, I thank you and your members for a beautiful program. And with this, I hand over to Dr. Keshav and then Dr. Rajiv Sood. Over to you, sir.
Thank you, Professor Chawla, and I must congratulate Dr. Arvind Ganpule and his members for a wonderful program. They have put in a lot of efforts to script this questions and get the answers with evidence. And good thing was that there were a lot of X-rays which are helping the students know what sort of questions will be asked in the exam. So this is a sort of a word round which can be useful to the students. And I think we will continue with this pattern of OSCEs in the other subspecialties also. And let me congratulate Arvind Ganpule for giving the talk, which was excellent. It was a surprise to me, but a surprise inclusion because I did not know about that. But it was an excellent talk, and I really enjoyed that talk. So over to you, Professor Sood, for your closing remarks.
Thank you, Dr. Keshav. It was wonderful session, and definitely I must acknowledge that Dr. Arvind Ganpule has improved upon whatever was started in the inaugural. That was the andrology subspecialty, and we are now going to handle each and every specialty. The students are going to be immensely benefited, and also they will know that what is the pattern. This is the exactly what we want, that uniform curriculum and uniform way of teaching. Their concepts are going to be clear. What exam is going to expect from them is very well knit in this program. And I hope that this program is guiding the basic mission of Indian School of Urology, that our uniform should be, education should be uniform, the functioning should be the subspecialty based, and all the people's involvement and the faculty is immensely benefiting the residents, and in turn preparation of such program itself gives a lot of training, lot of uniformity in imparting education. So one thing is should be clear to the residents, that whatever is shown today is there, and in addition I have handled the OSCE in National Board of Examination, and setting the papers and checking the papers, and we know that even some gross specimens can be photographed and can be shown there, or some histopathological questions should also be there. In addition, instruments are very well covered, and also all the expected questions are covered. Here, if you do well, you can score even 100%. So this is the beauty of such kind of exams, and it is not only upgrading your knowledge, it is ensuring the uniformity, and also it is creating the interest, and we know that how to handle the subspecialties and in turn the entire urology. Congratulations, Dr. Arvind Ganpule and all the members of EndoUrology team, and we will be with you very soon with another subspecialty, and our endeavor is that we cover all the subspecialties and all our residents are benefited. The way the audience is increasing, the participation of residents is increasing, the participation from SAARC countries is also there, and many people are now getting attracted to this kind of program, and this is the hallmark program of one of the hallmark programs of our endeavor of teaching, training, and imparting education. Congratulations to all. Thank you very much for today. Thank you.
For all the residents, I think there's a mock exam on 17th and 18th, which will cover only the short cases. So you'll soon get the information about that. 17th and 18th, 2.5, 3 hours of short cases, which we are planning to cover 11 or 12 cases by excellent faculty again. So please watch out for this and log into those mock exams next Saturday, Sunday. Thank you all.
Yes. And residents should know that we have covered 15 questions today. But in the actual exam, if OSCE is followed, there will be around 50 questions. So be ready for everything. Today, it needed a discussion in addition. So therefore, the number of questions were to be restricted. Thank you very much.
Thank you, Arvind.
Thank you, everybody, sir.
Thank you, Harpreet, Jishan, Rahul, and Deepak.
Thank you, sir. Thank you, sir. Keshav, sir. Thank you, Rajiv, sir, Arun, sir, Pankaj, sir.
Thank you, sir. Thank you, everyone. Thank you, sir. Bye-bye, sir.
It's a really good program. Thank you, everybody. Good participation.